your question. I hope you have understood how you will go ahead.
Yes, ma'am.
Not going to give you the easy, simple one. Gosh, are you outside freezing?
Sorry, ma'am.
Are you outside freezing?
No, sorry, actually. Sorry for the heavy breath. Sorry, sorry. No, it's not like
Put
that.
some warm clothes on so that you won't become ill before your exam. Okay. If you have read and understood, considering it clinical examination station, kindly begin.
I will enter the room. I will wash my hands. I will
Yes.
I will wash my hand. I will introduce myself.
Yes.
Good morning. I am Dr. Kuli, one of the surgical candidate. May I know your name and age of date of birth, please?
I'm Mark, 55 years old.
Hello, Mark. Today I have asked to examine your chest, which include looking, listening, and looking, feeling, and listening of your chest. Are you okay with that?
Yes.
I know you recently underwent a right hip replacement surgery 8 days back, and you suddenly have acute shortness of breath and chest pain. I will try to help you out with this examination. Is it okay with you? Shall I
Yes.
proceed?
Yes.
I just want you to sit comfortably. I will adjust the I will adjust the bed to 45 degrees so that you don't
Okay.
have feeling restlessness and shortness of breath. Is it okay with you, sir?
Yes.
Okay, sir. I will first of all inspect from the head and end side of the bed to look for the chest expansion, to look
Yes.
for the symmetry of the chest expansion, to look for any central cyanosis. I will look for the peripheral cyanosis. I will look for your hands. I just want you to just outstretch your hands. I will see for the tar staining. I will look for any fingernails. I will look for any fingernail brittling. I look for any skin brittling. I will look. Mark, I want to feel your legs. Do you have pain in your legs?
No.
I want to feel for I just want to feel for the calf tenderness to rule out DVT. I will look for the peripheral edema to look for the right. I will look for the peripheral edema to look for the pitting edema to look for the right ventricular failure. Then I will check for the. I just ask the patient to oppose both his index finger from side to side to look for the clubbing. I will look for the central cyanosis. I will ask the patient to open the mouth. I will spin out and stick out his tongue. I will look for at the hard palate. I will look for the tongue to look for the central cyanosis. I want the patient to just grab his lower eyelid, so look for the pallor, and I will check for the room for any oxygen cylinders or any inhalers or anything.
And
Then
the
I will
mask
ask the patient
on
and the
the
mask and I will look for the look for the chest for any scar mark, and I will look for any thoracotomy incisions or any axillary I will look for the axilla for any scar mark or any chest drain or anything. Now I will ask the patient, do you have any pain? Now I will feel your chest. Is it okay with you?
yes.
I will ask the patient to relax, sit 45 at the 45-degree angle, and now I will look for the temperature with the back of my hand. I will ask the patient, because it is a cold weather, you might feel some cold. I will rub my hands and will palpate the. I will check for the with the back of my hand. I will check for the temperature. Then I will check for the tenderness. I will then check for the apex beat, which is it is in the fifth intercostal space in the mid axillary line, just inferior to the nipple area. I will check for the apex beat. I will check for the position of the trachea with the using of my index finger. Before I checking the trachea, I will ask the patient to just relax and just slightly chin down to have a relaxed neck musculature, so that I will feel the position of the windpipe. And then I will check for the vocal fremitus. That is, I will keep my ulnar border of the hand in the chest, in the intercostal space, and I will ask the patient to say 99. I will check for the communication through my ulnar border of my hand. I will check for the movement of the chest. Sorry, ma'am, I forgot, in the inspection part, I have to look for radial pulse. I will look for radial pulse as well as the heart rate, ma'am.
Okay,
And
you are continuously telling, but I was thinking you'll realize yourself. How are you making mistake, or where are you making mistake?
sorry, I will complete first, ma'am. Yeah, then I will switch to percussion. I will ask the patient, sir, now I will tap on your chest. Is it okay with you? Do you have any pain? Hello, sir, do you have any
Patient is
pain?
not going to tell you, no. Patient is having sudden onset of chest pain. Yes.
Now I will, with the help of non-dominating hand, keeping in the intercostal space, I will tap with my dominating middle finger, and I will note the percussion note, and I will check for the. Then I will move to auscultation part. I will ask the patient to take a deep breath, and I will auscultate the chest with my stethoscope in the supraclavicular portion, infraclavicular portion, inframammillary portion, axillary portion, and the back of the chest. And then I move to the cervical lymph node examination. I want the patient to have a relaxed neck musculature. I will check for the submandibular, preauricular, postauricular, deep cervical, superficial cervical lymph node, supraclavicular lymph node. Then I will move again, checking for the sacral edema examination.
Okay. Can you present your case now?
Today, I have examined a 55-year-old male patient who is post-op day 8 of right hip replacement, presented with a sudden onset chest pain along with shortness of breath. On examination, I have seen he has a tender peripheral tender calf, right tender calf muscle. Along with, there is increased respiratory rate with decreased air entry towards the right side.
So what are your differential diagnosis?
My first differential diagnosis is a pulmonary embolism, pulmonary embolism, and second differential will be pneumonia.
What investigations would you carry out to confirm your diagnosis?
I will investigate the patient with a chest X-ray along with a baseline ABG to check for the pressure of oxygen, PaO2 and PaCO2, as well as I will check for spirometry.
Okay,
and
what is the management? Yes, what is the
CT
management
angio.
of pulmonary embolism that you can offer?
I will check. I will, after discussing with the multidisciplinary board, as well as I will check with the. I will check. Getting the CT angiography report. I will start the patient on anticoagulation therapy.
Okay, so if you were scrubbed in the theater and you were informed about the patient's current condition, what you would have done?
Sorry, I don't get you, ma'am.
If you were scrubbed in the theater and someone came up and they told you about the patient's current condition, what you would have suggested or what you would have done?
Ma'am, I have suggested the patient to start. We need to monitor this patient, ma'am, in a high dependency unit, ma'am, involving the intensivist, and we will have to start the patient on pharmacological and non-pharmacological anticoagulation therapy.
Yeah, you'll ask for immediate crash trolley. That's called.
Okay.
Yeah, all right. This was if you were doing exam like this, if this scenario came in the exam, they would have failed you. Why? Where have you gone wrong?
I have to start with a CRISP protocol, actually.
Yes, at where? That I even
in the
in the
starting.
middle told you, like, yeah, and even like before that I gave you hint, mask. So
Uh,
this patient, it's post-op and complaining of chest pain. Patient will have a mask on it. So once you did even say that you look for the cylinder, oxygen cylinder. So you look at it, how much oxygen is patient getting and why.
okay.
And the moment in the beginning, the moment you'll come to the patient and you'll ask, can I confirm your name and age? Patient will not answer you, right? Because patient is too into
Yeah.
pain to reply you. So if you'll move the mask and you'll make sure patient responds to you, so somehow patient will respond to you. Next question you'll ask, do you have any tummy pain? So patient will tell you that patient has sudden chest pain, but no tummy pain. So the moment you'll hear this, you'll begin your CRISP protocol.
Okay, ma'am. Actually, I thought because it is a examination station, matlab,
Yes, but
I
then you'll do the
actually
CRISP.
okay, okay.
Yes,
Actually, I thought to start with a CRISP protocol. I thought because it is looking like a pulmonary embolism or anything like, matlab, I
definitely it
conclude.
is, because here one thing is post-op of right hip replacement, hip examination, hip replacement, you know, it's your everyday life. You see
Yes,
these
ma'am.
sort of scenarios. And then sudden chest pain and the patient is post-op. And then how, in this when you'll start CRISP protocol, then how would you differentiate this CRISP protocol with the anastomotic leak or abdominal examination, which will also be post-operative, and that will be of anatomical anastomotic leak.
Ma'am, if in the anastomotic leak there is will be the history of hemicolectomy or any
Yeah,
surgery
yeah.
in the abdomen, then there will be
What
a
more?
then patient sorry, then patient must be wearing a TED stocking or something
Yes,
because
yes.
patient is lying down.
Here,
And
patient will not be wearing TED stocking, but patient will have a mask. So here, your examination I have not accepted. That's why I gave you this, just to see if you're aware of the differences. If it was normal chest examination, wait,
actually, ma'am, I
yes.
aware of the differences, but I am not able to apply actually. So so
Yes,
sorry.
now you've learned
Yes.
exactly when you'll enter and you'll ask, you'll confirm the name and age, patient may not respond you. You'll lift the mask up and then you'll ask again by giving eye contact to the patient. Okay.
Okay.
And then
Okay.
you'll ask again, and then patient will tell you that, then you'll ask the patient, do you have tummy pain? Patient will say, no,
Okay.
I only have chest pain and breathing
Okay.
difficulty, no tummy pain. Then the moment you hear this, you'll confirm, okay, then you'll begin the CRISP protocol.
Okay. Okay, ma'am. Fine. I understand, ma'am.
Then you'll go and you'll feel for the windpipe, and then you'll take a close look at the chest, and then you'll feel, you'll say, okay, I'm going to feel the chest, and then I'm going to listen to your chest. And then,
Then I will start with the like ABCD protocol. Okay, I will check for the
yes,
airway, the patency of the airway. I will ask
yes,
the patient he if he is oriented or not. I will if it is not able to hear me, then I will choose the chin lift and that all the things like
patient
that,
will
ma'am.
talk, I mean, will be aware. So maybe not chin lift, but then yes, those examinations. So it is different to chest examination, normal chest examination.
Okay, ma'am. Fine, ma'am. I will keep in mind, ma'am.
Yes,
Definitely.
just a second, maybe I can. Where is your question? Right. So if you have read and understood, considering it surgical and not station, kindly identify the structure that you're looking at. What is on the right side and what is on the left side?
Yes, on the right side, I'm looking at the medial surface of the lung or right lung, and the left side is the left lung with the hilum and the structures entering the hilum.
Okay. Can you please tell me the surface anatomy of the both lungs, right and left?
Yes, the apex. Firstly, the apex. It is marked by the line joining the sternoclavicular joint, and the point 3 centimeter above the medial third and the middle intermediate third of the clavicle. The anterior border joining the line from the sternoclavicular joint and the xiphisternum on the right, and on the left it deviates laterally from the fourth costal cartilage. Then the inferior border is the line joining 3 points: the sixth rib in the mid clavicular, eighth rib in the mid axillary, and the 10th in the thoracic vertebra. Then the posterior border from the transfer process of C7 to T10.
Okay, can you please identify structure 2 here, please?
2, it is the branches of the right pulmonary artery.
Okay, can you identify structure 3 here, please?
The groove for azygous vein.
All right, structure 8, please.
It is the groove for trachea and esophagus.
Okay, right, 10, please.
10 is the transverse fissure.
Okay,
Transverse fissure, horizontal.
All right, 7 over here, please.
It's the groove for supravena cava.
Yes, good. And 9, please. 9 here, 9 here.
Is the pulmonary veins, right
All
pulmonary
right.
veins.
Okay, over here, if you can identify number 3, please.
It is the groove for aorta.
Very good. 5, please.
Is the groove for subclavian artery, left subclavian artery.
Okay, can you please tell me 6? Identify the structure 6.
6 is the
Yes,
left
yes.
pulmonary veins.
All right, if you can identify structure 8. Where is 8? I have to look at myself. On
8,
the left
ma'am.
lung, 8.
8 is
yes.
the pulmonary ligament.
Very good. What is pulmonary ligament?
It is the fold of the mediastinum pleura that
Yes.
connects the medial surface of the lung to the pericardium,
And allows what?
and
The
it
expansion
allows
of-
the expansion of the pulmonary veins when there's increased blood flow.
Very good. Okay, can you please tell me for both right and left lungs, what are the structures which pass through the hilum of the lung?
Yes,
Both.
from
Yes.
above downwards in the
Okay.
right, we have the epiarterial bronchus, then the pulmonary artery, hyperarterial bronchus, and the pulmonary veins. And in case of left, we have the pulmonary artery, left main bronchus, and the pulmonary veins. And we also have bronchial arteries and veins, and then the lymph nodes and the autonomic nerves.
All right. How this hilum of the lung is different in both lungs, right and left? With in regard to location. The root of the right lung, what are the location? How is it different to root of the left lung? You have to think and consider, or maybe you can look here. What is this? Which lung is this?
This is the left lung.
Yes, and what kind of impression is this? Now
We have the cardiac impression there.
Yes, so this is what I wanted you to tell me. how the root of the left lung is different with regard to anatomy to right lung. This cardiac impression and what? Behind the mediastinal
Cardiac.
surface, and there's behind is cardiac impression of the lung. And what about on the right side? All right, okay.
On the right.
No, you can't. All right, can you please tell me about the anterior border of the lung? It extends from where to where?
Yes, it extends from the sternoclavicular joint to the xiphisternum.
Yes.
And in case of left, it deviates to the deviates laterally from the left fourth costal cartilage.
And the hilum is located at what level?
It is located opposite to the T5, 6, and 7.
All right, how many bronchopulmonary segments there are in each lung?
10, ma'am.
For both. All right. Can you please tell me the anterior and the posterior relation of the nerves in both lungs?
Anteriorly is the phrenic nerve. Posteriorly, we have the vagus and the sympathetic trunk.
Sympathetic trunk, yes. Okay. Can you please tell me how many parts, what are the parts of the right lung and the left lung?
Right lung has 3 lobes, the upper, middle, and lower, and the right
Which
lung,
are
and left lung
divided
has
by?
divided by 2 fissures, that is the oblique fissure and the horizontal fissure.
Yes.
And the left lung has 2 lobes, upper and lower lobe, which is divided by the oblique fissure. The lingular represents the inferior lobe in case of left.
Good. Okay. Can you please tell me if there is a clot which passes from deep veins and it has to reach deep veins of the cough and it has to reach to pulmonary artery, what would be its pathway?
It will begin from the popliteal vein to the
Yes.
femoral vein, then external iliac, common iliac, then the inferior vena cava to the right atrium, through the tricuspid valve to right ventricle, then the pulmonary trunk artery, and the lung.
Yes, pulmonary artery. Okay, good. Can you please identify these pictures beginning from 1 to 4? What is this picture 1, 9, 10, and 7? Can you identify? It's just taken from another book, but these are supposedly
it's
lungs.
not very clear, ma'am.
Yes.
9 is the horizontal fissure, 10 is the middle lobe, and
Okay.
down is 7, ma'am.
7, yes.
No,
That
7
is
is the oblique fissure.
Yes. Okay, good. So if the image of the lung is clear in your mind, then you can definitely identify, even if the picture is blurred. In the B, please. This is
the
pointing at-
left lung showing the oblique
Yes.
fissure.
Very good. 3, please. Now it's 1,
Is-
2, and 3 structures in the high lung. So supposedly this is right lung, maybe.
I think it's right lung, ma'am.
Yes, it's right lung. So tell me the structure present in the high lung, because if they do not give you diagrams or pictures from Macmillan Atlas, they give you from somewhere else. So you should at least be able to identify the structures in the high lung correctly.
Yes, in case of right lung, from above downwards, we have epiarterial bronchus, pulmonary artery,
Yes.
then the hyparterial bronchus, pulmonary vein.
Okay. This picture 4, if you can identify 4, 5, and 6, please. Supposedly
4
this is
is-
hilum of left lung.
Yes, ma'am. 4 is the pulmonary artery. 5 is the vein, pulmonary vein, and the 6 is in the middle. It's a left principal bronchus.
Good. Thank you. Bell has come back and we will just started, and here is your question. Right. So if you've read and understood, considering the clinical examination station, kindly begin.
Yeah, thank you, ma. I would want to wash my hands.
Yes.
I'll introduce myself to the patient,
Yes.
and I would confirm his name and age. Then
Yes.
I want to explain what I want to do to the patient by telling him I would give him, I will look, I will feel, and I also give him some instructions to do. If he's having pain while carrying out some of the instructions, he should let me know. I would stop. Then I would want him to expose himself. For this particular patient, I would want him to expose his entire lower limbs, right from the pelvis to the toes. Then I would also want, then once I've done that, then I would want to reposition the patient. In repositioning, firstly, I would want him to
If
stand.
you are exposing the patient, are you forgetting something?
If I'm exposing,
then you have to
yes,
ask.
I would want to also expose his upper limbs. I need the upper limbs to also be exposed. Upper limbs, lower limbs.
But then you'll ask
it will just
for
be on
who to be with you.
I'll ask for a chaperone.
Yes.
A chaperone.
Yes. Continue, please. Now, don't
Yes,
forget
I'll
that,
ask
because
for a
once you're
chaperone.
asking exposure, then you'll, yes, please continue.
Okay, thank you, ma. I would ask for a chaperone so that it will just be on his boxers, because I have to examine his upper limb too. So firstly, I would want to do a general examination in which I would concentrate more on the upper limbs. I'll look at his fingers. I'll look for any form of nicotine stains. If there are any splinter hemorrhages in the fingernails, I'll look at if there are any form of chronic changes on the fingernails, and also then afterwards I would want to do a radial. I want to assess the pulse, the radial pulse, and once I've done that, then I would move to the lower limbs. In the lower limbs,
if you want, you can answer your call. Someone is calling you. Okay, begin, please.
Okay, so I'll now concentrate on the lower limbs. First of all, I would want to inspect. I'll inspect the entire lower limbs. If there's, I would look at the skin, and also I would check for any form of a chronic venous insufficiency that is obvious. If there are ulcers, if there are scars on the lower limb. Then once I've done that, then I'll take permission from the patient before I touch. If there's anywhere he's feeling pain, then I would want to, okay, first of all, I want to test, I would assess for any form of differential warmth. Once I've done that, I'll test if there's any form of a differential warmth. For this patient, there might be coldness in both lower limbs. Then once I've done that, then I would also want to assess. I'll check all the pulses. First of all, I'll start with the right leg. I'll check the femoral pulse. I'll check the popliteal pulse, the dorsalis pedis, and also the posterior tibial pulse. And I'll also do a radiofemoral delay if there's any form of coarctation of the aorta. Then once I've done that, then I would also want to do the Burger's test. Right now, I will now tell the patient to lie down. I will ask if he's having any pain in the hip. Then I will raise once I've confirmed he doesn't have pain, I would extend the hip joint and also extend the leg. So once I've done that, I would note the Burger's angle, because there's an angle in which there will be there might be cyanosis of the limb. So usually for a normal patient, it should get to about 90 degrees. For this patient, it might get to about 20 to 30 degrees. So I'll note that.
Would the patient be lying down when you're doing Burger's angle test?
The patient will be lying supine when I'm doing this. Then I'll ask him to sit up.
Yes.
Then the limb, the ipsilateral
It
limb
should
I'm
be
examining.
swinging. Yes.
Yes, I'll swing the limb down.
Yes.
For a normal patient, because of reperfusion, there shouldn't be any color change. But for this
Yes.
particular patient, there might be some purplish discoloration.
Yes.
So once I've done this, I would also check in between the toes for any form of ulcers,
Yes.
in which this patient might also have. And once I've done this, then I would also, and I'll auscultate. I'll auscultate all the pulses with my stethoscope. Then once I've done this, I would also want to do, I'll request for, I'll do an ankle brachial pressure index.
Yes.
Because this is very important for this patient
Yes.
to assess the severity of the peripheral vascular disease. So once I've done this, I'll take note of the value. For this particular patient, it might be less than 0.4.
Okay.
So once I've
Can
done
you
that,
please present your case now?
I'll wash my hands, thank the patient, and also offer him assistance to dress him up.
Good.
In summary, I've presented a 72-year-old
I've
man
examined,
with
not presented.
I've examined.
Yes.
Yes, I've
Yes.
examined a 72-year-old man that is having has a bilateral peripheral vascular lower limb, a chronic lower limb ischemia bilaterally.
Okay.
His ankle breaker pressure index is less than 0.4. He has a bilateral ulcers, interdigital ulcers, and also is so that, yes.
Was there any, when you auscultated it, did you hear any bruit?
No, I didn't hear any brew. And both limbs were cold to touch.
Okay,
Both
in the
limbs were-
scenario, maybe you'll hear the aortic bruit. So, okay. So what are your differential diagnosis for this patient?
Yeah, my differential diagnosis is an atherosclerotic disease and also a diabetic. My first differential is a diabetic peripheral vascular disease, because this is a known diabetic patient with chronic limb.
So what investigations would you ask for to confirm your diagnosis?
Okay, the specific investigation I will require for an arterial duplex, a CT angiography, and also a magnetic resonance angiography.
And what labs would you ask for?
Lab investigations will include a blood glucose and also a lipid profile.
Lipid profile. Okay, what are the treatment options that you can offer this patient?
Yeah, the treatment option is, firstly, I would want to the lifestyle
Modification, yes.
Modification, risk factors. I want to ensure that the blood glucose is normal, discouraging from smoking if he's smoking, and also have the cholesterol levels and cholesterol levels to be normal. And also I might offer giving an antiplatelet agent. Then surgically, it might benefit from an endovascular, can I remember?
No, it's
okay, it might benefit from an endovascular intervention. Yes, maybe I could stent the, if the vessels that are affected could be stented to ensure.
If time would have allowed you, how would have you completed your examination?
Yes, I would want to carry out a full vascular examination of the upper limb.
Okay, yes, vascular, you were already, okay, vascular and neurological. And
yes, and the neurological examination of the lower limb. And also a cardiovascular examination.
Yes, and you will feel the abdomen for the presence of any aortic aneurysm.
Yes. Oh, yes, any aortic aneurysm.
So these you have to mention when you were telling me about the examination, and then you could have added quickly that if time would have allowed me, I would have done this as well to complete my examination. Right? It's important. So good. what are the things that you have forgotten because you got distracted because of the pulse, you know? So you
Yes, it
started
was
off
not
very
my
well.
not my phone.
It
Yes,
wasn't
I
yours.
didn't. It was
Okay,
not
sorry,
my
because
mother-in-law's phone.
all right. Uh, since when you began, you did the general examination very correctly. One thing you forgot, because once you were exposing the patient everything, like then you have to remember to ask the chaperone that you remembered afterwards. And then for the local examination, lower limb, you did the inspection, you looked for color, hair loss, scars, venous scattering, ulcers, any signs of chronic venous insufficiency, everything. Then I think you forgot to look for the tissue loss in the form of gangrene or amputation. Did you? I can't remember.
I didn't.
Okay. Then you looked for any deformities like pes cavus or claw toes or anything, or if there are any atrophic pulp of the toes.
Yes, ma'am.
Yeah, and then you did the examination, did the palpation, like you looked for the temperature, capillary fill, and then you told even the Burgers angle test. You took the pulses, right. When you took the pulses, then you have to do the Doppler as well. In the lower limb examination, Doppler will be there, right? If it's there, then you have to use it. And then you did auscultate iliac and femoral bruise, and you did the ankle brachial pressure index. So rest, you covered. So very good. Some things.
Yeah, I didn't do capillary refilling. I missed capillary refill for both upper and lower limb.
Yeah, that you have to. So next time we'll do again, and then you can practice the things that you have missed now, and we can do it again. Hopefully you 2-3 times you'll practice. And I normally tell everyone to practice each station 30 times, 30, you know. If you'll practice it yourself, like you'll stand in front of the mirror and you're practicing it, you'll improve. Or what you do once you're presenting it and you record yourself in your own mobile and you hear afterwards, you listen, you put the timer on, you record yourself and you listen, and then you keep on writing down the mistakes that you have done after checking it honestly, without any cheating. Then you record a second time. By the time you'll do this recording, re-recording and re-recording 30 times, you'll become perfect in one station and you'll never forget it. So this is my advice. It's worth practicing now than like paying the price in the exam. Thank you. Started, and here is your question. Right. If you have read and understood, considering the history-taking station, kindly begin.
Hello, I'm Dr. Moon, one of the exam candidates. Could you confirm your age, please?
I'm 67-year-old, Mary.
Hello, Miss Mary. How could I help you? What makes you today to come to us?
Doctor, for the last 2 months, I have 2 episodes of sudden falling on the ground after having some shaky fits-like episode. I don't know what happened to me.
I'm so sorry to hear that. Can you explain me a little bit more? When and where did it happen?
Doctor, actually, it started 2 months back. I was doing my daily activities at home. Then I had a episode of sudden shaking of my body, vigorous shaking of my body. Then I fell down. Then I don't know what happened to me. After 30 minutes, my wet clothes were wet, soiled with the urine, and I don't know. I don't
Who
recall
was
what happened for the last 30
at-
minutes.
who was present at that time?
Doctor, my husband is at home that time.
Okay. So can you just help me more by telling that exactly what did you feel that time? Did you have a flash of light before your seizures or chest pain, or you were restless that time?
Doctor, I felt some nauseating feeling before that event, but not like flashing of light or anything else. But I have some nauseating feeling before that. I feel some headache also. That's what
Okay.
I remember of.
Okay, I'm so sorry to hear that. Can you just tell me, or you can remember, at that time during your seizure, do you lost your consciousness?
Doctor, I told you earlier, I don't have any memory of that event for last that
Or
two episodes. I know that there are two episodes, but I don't know.
did your whole body shake? The persons who were with you, like your husband, did he help you to tell that? Did your whole body shake or a part of your
Yeah,
body shake?
my husband told me I shake as a whole unit, matlab, from head to toe.
Okay. And did you soil your clothes?
Yeah, I already told you, doctor. After 30 minutes when I wake up, I my clothes was soiled with the urine.
Okay, I'm so sorry to hear that. And at that time, did you have tongue bite?
No, doctor, I don't have any tongue bite, but I have a headache after that episode.
After the event, when you regain your consciousness, did you feel drowsy or weak or
Yeah, doctor, I felt
you?
very ashamed also, and I felt
Mm,
very weak. My husband
oh,
helped me to get to the bed.
I'm so sorry, Miss. I'm by hearing that you felt such conditions. Did you have ever feel like that before? Like you said that the last episodes happens when last time?
Doctor, I told you it was happened 2 months back.
2 months back. Before than that, do you have ever feel like that before?
No, doctor, I don't have any episode which I remember of.
Okay. Can you tell me the exact time, the daytime or nighttime when it exactly happened?
Yeah, doctor, it happened in the morning. I was preparing a breakfast for my husband.
Okay. And is anything makes it aggregating like when you have sleepless night or you have all day you have you sleep disturbance after that it happened or it happened usually?
No, doctor, I don't know any such factors which cause this as of.
Okay. So I do you have any morning headache like you feel so much headache during your morning time?
Uh, no, doctor, I don't have any headache, but I have the headache after the episode.
Okay. Did you feel any weakness in any of your part?
As such, no, doctor, but I felt a whole body ache after the episode. So my husband helped me to get to the bed.
Okay. And did you lose your weight?
No, doctor, I haven't lost any weight recently.
Do you have fever or neck pain?
No, doctor, I don't.
Do you have a history of fall down or trauma or any accident?
Uh, doctor, during the episode?
No, no, no. Before that you have any history of accident like head injury like that?
No, doctor. I don't have any such history in the past. But
Okay.
I am a diabetic, doctor. I want to tell you, I am a diabetic and I am on and hypertensive also.
Here you have medical conditions like for diabetes and hypertension. Did you take any drug for that reason?
Yeah, doctor. I am on medication, and my general physician told me it's well controlled on the medicine.
Okay. Did you ever admit in the hospital for any surgical condition?
No, doctor.
Can I ask you some personal question, please?
Yeah,
If you
doctor.
have,
Tell me.
Are you smoking?
No, doctor, I don't smoke.
And do you drink the alcohol?
No, doctor, I don't take
Any
alcohol.
any of your family members suffering this kind of diseases?
No, doctor.
Can you present your case now?
Okay, thank you for cooperating me. I will get back to you as soon as possible.
Okay, thank you, doctor.
Yes.
67-year-old lady came to me with a history of 2 episodes of falling down with vigorous shaking, and he made his history that he had fall at home in front of his husband, who told that he has complaining of severe headache before the seizures, and during the seizure he had the history of vigorous shaking, no history of soiling his clothes, no history of biting. And after the seizures, he regained consciousness, he felt very confused and drowsy. Usually it occurs in the morning time. Usually there is no, the triggering factor is his severe headaches and history of vomiting. And he has a history of diabetes and hypertension, which is well controlled. And he has no history of any kind of weakness or but he has history of severe morning headache. But
So
he
what are
didn't
your provisional
history.
diagnosis?
My provisional diagnosis is brain tumor,
Anything
as
else?
and there may be history of transient ischemic attack or strokes, or um, history of epilepsy.
How would you confirm your diagnosis? What investigations would you ask for?
So as for this patient, I will do blood glucose, complete blood count, mm, electrolyte, blood urea nitrogen, creatinine, calcium, magnesium, and lactate and prolactin level. And I will do CT scan of the head to exclude is there any intracranial lesions present or not. And I
Anything
will also
else you
do
want to conclude by doing CT head?
I will
Anything else you want to rule out?
by CT head.
Yes,
Ma'am?
please. Yes, please.
By CT head, I will exclude if there is any because she has a history of fall. Is there any trauma in his head, in her head,
Yes.
or
Yes.
head,
All
or
right.
any
Yes.
lesions?
Trauma. Yes. Next.
Yes. Next, ma'am, I will do lumbar puncture to exclude any infections, and MRI by consultation with the neurologist.
Okay. So what are the treatment options that you can offer to this patient?
Okay, at that moment when she has experienced seizures, it is always move to the safe place and turn to the left lateral positions, and
This is the management, but the treatment I asked you, please.
okay, ma'am. For seizures, I will do IV line, give him oxygens, monitor his vitals.
What is the treatment of
and
epilepsy?
I will
If it is not epilepsy, your first diagnosis was tumor.
ma'am, at
Then-
first,
So you'll discuss in MDT team, and depending upon the cause of the illness, you'll decide the treatment or management as well.
yes, ma'am.
This is the all answer, you know. Thanks.
Yes.
Okay, so I'll ask you, what are the things that you have forgotten or missed or could not, summary is too long, yes, that you could not cover in the given time?
Yes, ma'am. I didn't complete to ask her what is her profession, and at the last ICE, what is his
ISCS,
expectations
yes,
from
family history.
I until the family history.
Okay, all right. And in the history itself of the present condition, What was something that you forgot to ask or double check? You did ask if patient was shaking and who was witnessed and what they said, what they realized. But you did not ask if the witness has told the patient that once she fell, she struck her head as well. So head
Okay,
trauma,
ma'am.
you did not rule out. It was very important because
Yes, ma'am.
patient has fallen down for 2 times, right? So if
Yes.
first time patient head has not came in contact with the ground, has it come the second time? Or if it came first time and it didn't come in second time, the second time this fall was because of something else. So
Yes,
what
ma'am.
type of, yes, hemorrhage Dr. Kuldeep wrote, but what type of hemorrhage would that be? Was it like subarachnoid hemorrhage? See, subarachnoid hemorrhage can be patient can complain of severe headache and then, okay, patient is collapsing and then there is hemorrhage. And the another type of hemorrhage could be patient has fallen down and because of the trauma or because patient has fallen down very rapidly, so there has been blood hemorrhage, like there has been injury. So diagnosis becomes totally different, it's not the same. And if it is like morning illness, like you said, a patient has morning illnesses and then patient feels vomiting and nausea in the morning and there are no weaknesses. So there could be tumor, right? So
Yes, ma'am.
one more thing, second of differential diagnosis, you said stroke. But when you were presenting history, you did not mention that there was no positive sign of any weakness. Then stroke.
Oh, ma'am. About the weakness, you said no.
Yes, you did
Yeah.
ask, but then yes, then you cannot have stroke as a differential
different
example in the second.
Yes.
TIA is all right, very good. You said tumor, TIA, and then maybe hemorrhage or epilepsy. Then if it's epilepsy, then what type of epilepsy? Because it also has types. Then you should know those as well,
Okay,
right?
ma'am.
Yeah. So once we'll do this session again, right?
Okay,
You'll
ma'am.
go back here and we'll improve and we'll come back. Yes, please. Right, so if you have read and understood, considering it's surgical pathology station, kindly tell me what are your differential diagnosis for this patient?
My differential will be, ma'am, inguinal hernia. My differential will be ectopic testis. My differential will be lymph node lymphadenopathy and testicular malignancy.
And dragging pain?
Ma'am,
Very
it
good.
can be
All
a
right.
varicose.
Yes, you should know that. All right. Okay. Considering the age group of the patient, what is the most likely condition that you expect?
Ma'am,
Please don't say
considering the
hernia.
no, ma'am.
Your first
Ma'am,
diagnosis was hernia, and I'm not happy with that. Okay. Yes, please.
okay.
Focus. Yes.
Ma'am, considering the age, it can be a teratoma, ma'am.
Okay. Why? Convince me, please.
Ma'am, because it is the most common malignancy in the post-pubertal period, ma'am.
Okay. What if the patient's age was above 35 years of age? Then what was the
Ma'am,
most common?
most common tumor then will be a seminoma, ma'am.
All right. So how would you confirm which type of malignancy that is? What are the blood
Ma'am,
tests you'll ask for? Yes, please.
Ma'am, I will investigate the patient with a tumor marker like
Like?
LDH, like beta HCG and alpha fetoprotein, ma'am.
Okay. Any other
Beta
placental?
HCG,
Okay.
placental alkaline phosphatase, ma'am.
Yes. That would be raised in which condition?
Ma'am, it will be raised in seminoma, ma'am.
Seminoma. Very good.
As well as beta HCG will be raised if there will be cytotrophic proliferation in seminoma tumor, ma'am.
Okay. If you have to confirm your diagnosis, what are the steps that you would follow?
Ma'am, to confirm the diagnosis, we need to do a orchectomy and we need to do a lymph node biopsy. Then we need we will investigate. We will need to have a CT abdomen, CT pelvis, CT chest, ma'am. Then we need to discuss it in MDT board.
Okay. All right. Can you please tell me if it's seminoma? So what is the origin of cells?
Ma'am, it will be the germ cell tumor, ma'am.
Precursors. Okay. And how
precursor
will
lesion?
yes.
Precursor lesion will be intertubular
Tubular
germ
germ cell
neoplasia in situ.
How would it appear on histopathology?
Ma'am, on histopath, it will show large cells with the vacuolated nuclei with interspaced lymphocytic infiltration.
How would you differentiate a seminoma on histopathology with teratoma?
Ma'am, teratoma will be having a different all the type of lineage with endodermal, ectodermal,
Yes.
and mesodermal. But seminoma will be having a single cell lineage, and in teratoma we will see a cystic lesion with hair,
Yes.
teeth,
All
and
right,
cartilage.
good. Can you please tell me how the management differs depending upon the histological report?
Ma'am, seminoma is very chemosensitive. So we do the orchectomy and we start the patient on chemotherapy. And in the teratoma, ma'am, teratoma in the younger patient, in young adult, in the young patient has a very good prognosis and it is curable after chemotherapy. But in old age, older age group, it has a poor prognosis, poor response to chemotherapy.
Okay, what about the radiotherapy? In which situation radiotherapy is valuable or effective?
Ma'am, radiotherapy is valuable in choriocarcinoma, ma'am.
Seminomas.
Okay.
Yes.
Ma'am, seminomas are very good for chemo sensitive. What
But you will not give for teratomas, you will not give radiotherapy. Okay. Can you please tell me the overall prognosis of testicular carcinoma? Overall,
Ma'am, testicular tumors has a very good prognosis.
Yes.
I think 95 survival rate is 80 to 85. Yes, survival rate is there in testicular malignancy.
Less than 50% have poor prognostic. Okay. Can you please tell me what are the steps that you will use or you will follow what are the steps you will follow for the follow-up of the patient to monitor the recurrence?
Ma'am, I will follow up the patient with the tumor markers like beta HCG, placental alkaline phosphatase, and alpha fetoprotein, along with the for a minimum of 5 years, ma'am.
No,
every
10 years.
2 years.
According to NICE guidelines, you have to follow the patient for 10 years.
Okay, ma'am.
All right. Can you please tell me what are the most common sites where these primary tumors metastasize to? That is one. Three I said.
First is paraaortic lymph node. Then, ma'am, it goes to liver. Then goes to lung.
Okay. What is their mode of spread?
Ma'am, they spread through hematogenous spread, ma'am, to the para-aortic lymph node. Sorry, lymphatic spread to the para-aortic, lymphatic spread to para-aortic lymph nodes.
Okay. Can you define the term metastasis?
Ma'am, metastasis is the survival and spread of the tumor cells distinct from the primary site of a region.
You mentioned a term choriocarcinoma. What can you define it? What is it?
Ma'am, choriocarcinoma is a type of testicular malignancy in which there is a pluripotent cell modified to the trophoblastic cells, which contain both type of cytotrophoblast as well as cytotrophoblast, and the tumor marker will be SEG.
Okay, and choriocarcinoma is characterized by early hematogenous spread to the lungs.
Yes, ma'am.
Okay, can you please tell me what is beta HCG? It's abbreviation of what?
Ma'am, beta HCG is beta human chronic gonadotrophin hormone. Gonadotrophin.
Can beta HCG measure seminoma's recurrence?
Ma'am, if there if there is cytotrophoblastic proliferation in seminoma, which is seen in 15% of the seminomas only.
Okay, according to WHO classification, can you classify testicular tumor?
Ma'am, testicular tumors can be classified into seminoma type, non-seminomatous germ cell tumor, sex cord stromal tumors, and lymphoma, ma'am.
And there are other types as well: soft tissue tumors, secondary tumors, light lesions, and paratesticular tumors. Okay. Bell has gone. All right. If the age of the patient, just suppose here patient is young. I did ask you if patient was over 35 years old, but then if a patient's age is 70 years old and patient presents with a growing mass, what would be your what would be the most likely diagnosis in that case?
Then it will be a non-Hodgkin lymphoma, ma'am.
Yes, lymphoma. Good. So what are the risk factors which are associated with it?
Risk factor associated with testicular tumor, ma'am?
Yes, please.
Ma'am, the risk factor are the risk factor will be, ma'am, first will be ma'am, first will be cryptorchism or undescended testes, ma'am. There will be a gonadal dysgenesis and genetic, ma'am.
Okay, this was the okay. You told me right. Once you have confirmed your diagnosis and you know that it's malignancy, what are the complications that you expect?
Ma'am, complication will be testicular infertility, ma'am. It will be
that doesn't matter. It's malignancy. Okay. So what are the complications that you should expect considering that it's malignancy? So patient will be hypercoagulable, and there could be virtuous triad for DVT that you should expect. These are the common things, right?
Okay.
So these are the things that you should expect.
Yes, ma'am.
Good. So what measures would you suggest? Since considering its malignancy and there are risks for DVT, so what are the measures that you'll suggest to the patient?
Ma'am, I will suggest the patient to have we will start the pharmacological and non-pharmacological therapy. In non-pharmacological, like pneumatic bandages, like elastic stockings, ankle pump exercises, and in pharmacological group we can start the patient on low molecular weight heparin, like an oxap.
Yes, good. Thank you.
Thank you, ma'am.